welcome to the Modern Gastro Podcast, a GI community chat, which is hosted by Commonwealth Diagnostics International. I'm your host, Craig Strasnick. I'm the president and CEO of CDI, and I am thrilled to have you join us here today. Modern Gastro is a series of educational resources for the GI community, including podcasts, magazines, and email newsletters, all with a focus on functional GI trends and insights from experts around the globe. In each of our GI community chats, we dive deep into the world of gastroenterology, bringing you enlightening discussions with industry experts, healthcare professionals, and thought leaders who are making a difference in our field. Today, we have one of those and a wonderful guest with us, someone who brings a wealth of knowledge and expertise to the table. Please welcome Tamara Freuman, a New York-based registered dietitian, author, and America's trusted digestive nutrition expert. In addition to her Manhattan-based practice at New York Gastroenterology Associates, she has written now 2 books. Her debut book, The Bloated Belly Whisperer, was published in 2018, and her latest book, Regular, which I've read and have a copy of here, was just recently published. Welcome, Tamara, and thank you for being here.
Thank you. Thanks, Craig. Thanks for having me.
Absolutely. We are honored to have you here today, and truly your expertise in gastrointestinal nutrition and your dedication to improving patients' lives is genuinely meaningful. It's impactful. It's also practical and insightful. After reading Regular, I can say that personally, and I think that your personalized approach is one that we also try to emulate at CDI, and I am hopeful that many other practitioners in yours and our field will do the same. So I'm excited to dive into this discussion with you today. I wanted to start there by talking about your new book on irregularity and explore some of the recommendations you might have on root cause diagnostics, personalized treatment plans, etc. I thought it might be helpful to give our audience a quick blurb on your new book, taken directly from Amazon, of course, but can be found in all your local distributors, but this is how the summary of Tamara's new book reads on Amazon. So it reads the following: belly bloat, diarrhea, constipation, irritable bowels may not seem like the sexiest topics, but they still affect millions of Americans every year. Rather than focusing on a single one-size-fits-all approach to restoring bowel regularity, Regular aims to help readers identify the likely cause of their irregular bowel patterns and offers a wide variety of personalized solutions. For example, Freuman explains that while a high-fiber diet that might help someone with slow transit constipation, it could make symptoms worse for someone constipated as the result of pelvic floor muscle dysfunction. Regular will guide readers to narrow down the specific cause of their irregularity and provide tips, including questions to take you to the next doctor's visit, table listing foods likely to be problematic and suggested alternatives, sample menus for different therapeutic diets, and foods and supplements that may be helpful for specific types of diarrhea and constipation. Whether you're dealing with chronic diarrhea or constipation, Regular will cover a dozen of the most common causes of bowel irregularity with detailed descriptions of their presentations that a sufferer should recognize, including irritable bowel syndrome, lactose, fructose, and sucrose intolerances, malabsorption conditions, including SIBO, bile acid malabsorption, celiac disease, and pancreatic insufficiency, histamine intolerance, inflammatory bowel disease, including Crohn's and ulcerative colitis, and pelvic floor dysfunction. So that's a lot. We could start anywhere, but I think maybe first off, if you could start with where some of the inspiration behind this book came from, and a key message, maybe generally, that you would like to share with your readers, both patients and healthcare providers alike, and what you'd like to see them take away from it.
Sure. So, as with my first book, my inspiration is always my patients and the world of patient or prospective patients who I may never get to work with. Um, Even when my first book was sort of coming out in late 2018, people were already messaging me during the pre-sale period, asking, "Oh, does this book cover Crohn's disease? I have Crohn's disease. Is it going to help me? Oh, does it talk about IBS? I have IBS." And the answer was kind of like, kind of, right? I was talking about bloating, which was a symptom, but my first book really didn't kind of tackle a lot of very specific diseases in their entirety. It spoke about an aspect of many different conditions, but not the full condition. And so someone who was really struggling with diarrhea or constipation may or may not have found an answer completely in my first book. And so it was pretty clear to me that there was probably another book that needed to be written that was much more squarely focused on answering the questions of chronic diarrhea, chronic constipation, or in people who already had a medical diagnosis but didn't really know how to manage that condition, to really deep dive on some of the really most common medical diagnoses that people encounter, and look at it from all angles, from a diagnostic angle, from a medical treatment angle, from a nutrition angle, from a supplement angle, so that people could really just be empowered to understand their diagnosis, understand all of the options at their disposal to improve their symptoms and their quality of life. And so that was really the origins of this book. And to your second question about kind of key takeaways coming out of that, I mean, as with everything I do, I really always emphasize individuality and personalization. And so, whether you have diarrhea or bloating or whatever your symptom is, your bloating may not be the same as your next door neighbor's bloating, or the cause of your diarrhea is not the same as your mother in law's diarrhea. And so, while people try to be helpful, or people online try to give you these sort of infographics that are, if you have bloating, eat these foods, or if you are constipated, eat these foods, that may or may not have any relevance to you. Unless you really understand what's going on physiologically in your body, you're not going to have a relevant treatment. And so this is really all about helping people read the clues of their own bodies, understand how to decode their own symptoms, know what to talk to their physicians about so that they can get an expeditious diagnosis, and they're not, back and forth for years and years with testing and appointments trying to figure this out, so that you can figure out what's going on quickly and home in really on a solution.
Yeah, this is endlessly fascinating and I think critically important. One of the things that jumps out for me is this idea that many patients, functional GI patients, or disorders of brain gut interaction, as they're currently being called, uh, may have the same symptoms, but for very different reasons. And there's a distinction with a very real difference there. And I think one of the challenges that many people face when it comes to digestive health is distinguishing between what may be normal variations in gut function, or a potential underlying, more serious condition, i.e., the pathophysiologic versus the anatomic abnormality. So what point do you recommend, Tamara, people seek appropriate professional help versus what guidance do you provide to your patients to navigate through the complexities of their gut health, maybe on their own or under the guidance of a multidisciplinary care team? Many times over, we're seeing now and having conversations at CDI with gastroenterologists who are also working with dietitians, with nutritionists, and they're diversifying their treatment plans to incorporate a whole other set of disciplines that they may not even have been thinking about 5 or 10 years ago. So I think that's a really critical component here too.
Yeah, absolutely. I think there's probably two answers to that question. So, the first is, if you have any alarm symptoms, you need to see a doctor. Like, do not pass go, go straight to the doctor, right? And we're talking about things like blood in your stool, or vomiting, or waking up overnight, to have bowel movements, which isn't necessarily an alarm symptom, but that's not normal. Very kind of sudden onset change, like severe and sudden onset changes in your bowel function. Like one day you're completely normal and regular, pooping every day once or twice, and then literally you just completely stop going entirely. These very sudden changes. Acute pain, like very severe pain, the kind of pain where you're thinking like, should I go to the ER? These are things that should really be sending you to see a physician sooner rather than later. But then I think that there's another piece, is that people who have chronic conditions or chronic symptoms for, like, a really long time, which, like obviously isn't something that would have killed them, because they're they're still alive 10, 20 years later. But if your GI function is occupying more than, 30 seconds a day of your mind share, and you're actually really kind of thinking about your bowels and your pooping, and oh my gosh, like waking up hours before work, or skipping social events, or skipping meals, or really kind of contorting your entire life or job or travel schedule or eating schedule around your bowels, you should get some help. Like, that's not normal, and you shouldn't have to live like that. There's very, very few people that we can't find solutions for that make their lives substantially better, even if it may not be at 100%. There's solutions for almost every condition, and people should not have to live like that.
Yeah, they absolutely should not. I couldn't agree more. This is a topic that is near and dear to my heart personally. It's near and dear to many of our team members' hearts at CDI. Something we talk a lot about. I think many of these patients are disregarded or discarded. Sometimes they have seeing multiple specialists, and if there isn't something anatomic, then they're left on their own to have to deal with it on their own accord. But to take your example of a patient that may present absent alarm signs, if they fit a profile, it's, let's say, a 25-year-old female that is absent alarm signs, there's no blood in their stool, they're not losing a tremendous amount of weight, etc. But they are experiencing a tremendous amount of ongoing digestive disturbance. To altogether discard this idea of a pathophysiologic discrepancy, leaves them to spend a lot of time and money trying to figure it out on their own, when there may be other diagnostic approaches that won't necessarily find inflammation or a blockage, but may find something else going on there. Any one of these other a multitude, I think it was 11 disease categories that you allude to, that are functional in nature. They aren't necessarily anatomic, but they're important nonetheless, and they're diminishing the quality of life for these patients. So with that as some pretext to my next question, I wonder how we kind of bridge that gap between patients and providers, and how we continue to educate healthcare providers on functional GI disturbance, and how can they more routinely work that into a standard of care that doesn't make these patients feel so diminished a lot of the time. You have a lot of insights and strategies in your book, and I'm wondering how you think those can be applied and help other healthcare providers kind of better support patients dealing with digestive distress to improve their overall well-being.
Yeah. I mean, I have so many thoughts about that. I mean, the first thing I will say is, a lot of these patients carry a diagnosis of IBS. And we know statistically there are a lot of conditions that present like IBS. I like to call them IBS mimickers, that sure as heck look like IBS, but they are not IBS. And when you look at the incidence of these, so I think bile acid diarrhea is a really good example. It's estimated that 25%, maybe even more, of people who carry a diagnosis of IBSD actually have bile acid malabsorption. I think I've seen statistics around 7 to 10% of people with IBSD actually have sucrose intolerance or sucrose malabsorption. And so when you start to put those numbers together, you have to acknowledge that there is a significant percent of your patients who are carrying an IBS diagnosis who on the surface do meet the diagnostic criteria for IBS, but they're not getting better with the standard IBS interventions. Someone with actual IBS will almost definitely respond to one of the many, many interventions we have for IBS, either soluble fiber supplementation or soluble fiber therapy, or FODMAP elimination or FODMAP restriction, or antispasmodics, right? Or, we doctors have a lot of medications. I have a lot of diet interventions. And if you have someone who carries an IBS diagnosis who doesn't respond to any of these things, rather than write them off and say, well, it's all in your head, maybe we have to step back as providers and say, hey, I wonder if they actually have IBS. Maybe I
That's
need to look at this with a fresh set of eyes and really kind of look a little bit deeper and consider one of the IBS mimickers, of which there are many, right? A lot of people with pelvic floor dysfunction are diagnosed as IBS-C, right? But they don't respond to any of the secretagogues or any of the laxatives that typically people with IBS-C respond to. And they might feel worse on a high fiber diet, whereas someone with IBS-C feels better. And so, when you start to notice that your IBS patient is really exhausted all of your treatment options, I think that's really a moment for all of us clinicians to pause and say, wait a second. Before my knee-jerk reaction is to blame the patient and write off the patient and say, like, they're too complicated, it must be in their head, I can't help you. Consider one of the mimickers. And that's really what I try to draw out in this book. A lot of the conditions I talk about in my book are actually, I talk about IBS, but I also talk about IBS mimickers and how
Mhm.
we can differentiate them clinically.
Yeah, and this provokes a whole other school of thought for me, a whole host of other thoughts for me, really. But I'm wondering, how do you use some of these concepts in the book to empower healthcare providers to take this more comprehensive and effective approach? I see this really as more kind of changing the outlook or the mindset on what has always been a conventional approach to digestive illness, and more of this one size fits all application that so nicely explained in the summary of your book. But and I'm not necessarily talking about integrative approaches. I'm talking about alternative approaches. Diet, promotility agents, things that aren't necessarily just antibiotics or procedures to address, or drugs for that matter, or procedures to address digestive distress. How do you work that into the care continuum a little bit earlier on in the workup of some of these functional GI
Yeah.
patients? I think is my first question. Then I'd like to branch that out a little bit further into how does diet play a role overall, in either directly or supplementally in treating these patients?
Yeah, so I'm a dietitian, so the tools that I have within my scope of practice are diet and evidence-based supplements, which there are some, but not all that many if we're actually holding it to a standard of evidence. And so, you know, what I like to do using diet is if somebody doesn't have a diagnosis, or, somebody is not doing well managing their diagnosis, I actually like to use diet interventions as a sort of proof of concept tool as far as exploring a hypothesis, or a diagnostic hypothesis. And so if I think that maybe you have, a histamine intolerance, or you're reacting to histamine foods, before we go to your doctor and your doctor gets dismissive, I will put you on a 2-week low histamine diet. And if you feel better and your IBS symptoms go away, then we can go to your doctor and say, hey, I was
Yeah.
having all these symptoms, and you know what? They got better on a low histamine diet. What does that mean? And maybe the doctor will then send you to an allergist immunologist. Maybe they'll put you on Pepcid, or, famotidine, or H2 blockers or something, or, but that already kind of gives them a lead that then they can kind of pursue further evaluation, further testing, further treatment, or further referrals. And so I like to use diet to kind of help provide proof of concept, or also rule things out, right? So if people think, that they have, IBS or SIBO or something, and I put you on a very strict low FODMAP diet for 2 weeks, and you literally don't feel any better and your gas is still just as bad, well, I got to look for another reason for the gas. It doesn't make sense for me to keep you on a low FODMAP diet for the rest of your life. You didn't get better. Let's move on. Let's maybe look for
Mhm.
stool burden. Maybe that's why you're full of gas. Maybe it's sucrose intolerance. That's why you're full of gas. Maybe other things like malabsorptive types of things. And so, I like to use 2-week diet interventions, or your response or lack of response to them, to really help provide another data point to my MD colleagues, who can then use that to expedite their differential diagnosis and get to an answer faster. And so I view us as partners in that regard.
And I think that data is hugely important, getting those feedback loops from the patient in real time and understanding in kind of a shortened window, a 1 or 2 week time frame, how that diet is affecting their symptom set is incredibly important. One kind of piggybacking off of that question, but staying on the theme of diet, is patient compliance. Are there any particular kind of strategies or tactics that you use to ensure, using FODMAP as an example, it's a complex diet. It's hard to maintain compliance with it. Anybody trying to do so, I've tried personally, and it's hard to stay on for a period of
Yeah.
time beyond a few days. 2 weeks, 2 months is, kudos to anyone who is doing that. There are apps, there are digital, applications out there right now that help or assist. But are there any specific feedback loops or channels of communication that you've implemented with your patients to be able to kind of coach them along in the process of the journey? Because much of this work, I should say, is done outside of the office. You're not necessarily
Yeah.
able to be there in real time with these patients to ensure that they are maintaining compliance with something like a FODMAP. So I'm just wondering if there's anything you've seen
Sure.
used successfully to supplement that process.
Sure. Well, I'll start by saying that these diet interventions that I take on, very early in the process to kind of give proof of concept to see if it's helpful, they're 2 weeks. I never go longer than 2 weeks, for precisely the point that you're making, which is adherence starts to wane after 2 weeks. Most people, especially most people who are suffering and feeling terrible, are willing to follow anything you say or ask of them for 2 weeks, especially if you choose a 2 weeks where they don't have a vacation planned or a wedding plan. So I do think like choosing the right timing makes sense.
Absolutely. Yeah.
And on something, most of these therapeutic diets, whether it's low FODMAP, low histamine, low sucrose, low nickel, whatever I'm doing, you will know within 2 weeks whether it's helping. You don't need more than 2 weeks to know if it's helping. And then once somebody really, like, if that is like, wow, that's super helpful. For many, many of these therapeutic diets now, we're having other tools, especially like newer enzymes, like evidence based enzymes, that will actually help them maintain a less stringent version of the diet if they need to be on one for the longer term. So, for example, as you know, someone who has sucrose intolerance, if we can prove it with a test, they can get prescription saccharicidase and they don't have to avoid sucrose. Someone who really has a horrible FODMAP intolerance or multiple FODMAPs, especially that fructin category, we now have two new enzymes in the market with one has fructin hydrolase and one
Mhm.
has an inulinase, that these patients, many of my patients now don't need to avoid onions and garlic and wheat. They can just, take these enzyme cocktails that are very specific to FODMAPs. They have one for galacto-oligosaccharides, one for fructans, lactose, fructose. And so, most of these patients will only really need to avoid maybe polyols if they're sensitive to them. And so, once I know what the problem is, I like to give people tools to help them manage their symptoms so they do not have to follow very stringent diets for very long periods of time. Obviously, there's exceptions to that rule. Celiac disease is a bear. We don't have anything for celiac disease. Gluten-free diet, very strict for life, is what it is. And I mean, we all see
Mhm.
the data that adherence really varies for people to their own detriment. People who have, like a nickel, like a systemic nickel allergy, I don't know of any way to mitigate that other than avoiding nickel or minimizing dietary nickel intake. And so there are some things that once we figure it out, then you have to choose like how you're going to feel and how healthy you're going to be. But for most of our therapeutic diets, there is wiggle room and there are tools for fiber tolerance, for fat tolerance, for FODMAP tolerance, for sucrose tolerance. And so, I like to give my patients as many tools as I can.
I think that's spot on, and you also see a tremendous amount of success cases, patients that are able to maintain compliance with a specific diet over a certain period of time, and while relapse is always a potential issue, they feel quite better for a quite certain period of time thereafter. So, I think that it's not a silver bullet. Nothing is when treating these types of cases, but you know, diet is a very robust tool to be included in the bag of tricks for sure. I think staying on this topic of patients and kind of a holistic multidisciplinary approach. Look, the name of your book is regular, but the subtitle is The Ultimate Guide to Taming Unruly Bowels and Achieving Inner Peace. That's what it says here at the top. And those two things go hand in hand, the connection between digestive health and mental health. And there's growing recognition in a number of different areas of the connection between digestive health and mental health. And I'm just wondering, either generally or specifically or both, if you could maybe, if you would like to elaborate on the connection between how improving digestive health can positively impact one's overall well-being and this ultimate journey toward finding inner peace.
Yeah, I mean, so the inner peace was obviously referring both to mental inner peace as well as digestive inner peace. But
Sure.
I mean, look, we all see the data on, quality of life and all this patient surveys, especially IBS patients who, report being willing to trade several years of their life just to get rid of their IBS. And so, these conditions take such a toll on people's quality of life, their willingness to take vacations, their comfort with dating, their comfort with socializing at restaurants. And, when you can give a patient tools and, management tools and symptom control, I mean, it gives you your life back. And that's not an overstatement. I mean, it really gives you your life back and to just not have this constant worry. I mean, patients who are having like accidents or near accidents, when they're at the supermarket or on public transportation, that is devastating. There's people, I mean, I have patients who've been teachers who have stopped working because as a teacher, you can't leave the classroom of young kids to go to the bathroom. So they just give up their careers. I mean, so it's not hyperbole to say that when you get your bowels under control after like a chronic lifelong GI condition, it's not hard to see how that would have just literally a life-changing impact on your mental health and your quality of life.
Absolutely. It's so important. I was just reading an article recently that blew me away. A study, I think it was in Europe, but just absenteeism, presenteeism data relative to functional GI disease. And it was really mind blowing. I mean, I know personal stories of patients of ours that have lost their jobs because of the number of days that they had to take off because of their digestive
Yeah.
distress. But on a global scale, it's truly remarkable. And I'm very pleased and thankful that we have people like you, Tamara, who are calling attention to it and publishing things in public domain that are calling attention to the need for it. So I think that is as good a place as any to kind of draw a close here. Before I make my own, Tamara, are there any closing remarks that you'd like to make? Any final comments about your book? Anything we discussed here today or otherwise?
Oh gosh, I mean, I could talk about this book forever.
The floor is
Look, I
yours.
mean, obviously, I know that this is a podcast that is also listened to by a lot of healthcare professionals, not just patients. And what I will just say about that is, I wrote these books not just for patients. I wrote these as kind of textbooks that I never had when I was when I was going through my education. I'm getting my master's in clinical nutrition and training to become a GI dietitian. Um, I mean, my textbooks didn't even talk about IBS. I mean, I think that they're better now, but it took me a couple years out of practice before I even learned about the low FODMAP diet. And, and almost everything that you read in this book are things that I learned on the job from a gastroenterologist who really took me under his wing and mentored me and taught me everything he knew. And from seeing thousands of patients over, 13 years. And so I wrote this book for fellow dietitians and frankly, even for, generalist gastroenterologists who don't see the weird stuff as often as we do in New York City, I guess. There's just like some really helpful things that all clinicians can offer our patients that aren't prescription drugs, although certainly I have no beef with big pharma when it comes to helping people. I'll take whatever help is available. But there's some really cheap and cheerful over the counter solutions that can be life changing. A well chosen fiber supplement can be life changing. Some of these new FODMAP enzymes can be life changing. And so I just want to make sure that my fellow practitioners are also armed with the latest and greatest clinical practice gems, evidence based, that they can also bring to their patients. Because this stuff is not compiled in this way really anywhere. And so I wanted to really put that together as the textbook that I never had.
No, thank you for those insights and for doing that. I think that's fantastic. And from our perspective here at CDI, we want to thank you, Tamara, for joining us, and to our audience, thank you all for joining us on this episode as well of the Modern Gastro Podcast. I hope you guys all found our discussion with Tamara insightful and thought provoking. I know that I sure did, and the field of gastroenterology is ever changing and evolving, and staying up to date with the latest research, diagnostic, treatment strategies. It's vital for providing the best care to patients, and continuing to expand upon that care continuum is ever critical. And so, as always, we encourage you to continue the conversation online using the hashtag GI community, sharing your experiences, your expertise, questions with fellow healthcare professionals, etc. Together, we believe we can make a difference in the lives of those affected by digestive distress. And if you enjoyed today's episode, please be sure to follow CDI on social media for the latest modern gastro publications. So, with that, thank you again, Tamara. And until next time, keep exploring and keep making a positive impact on your patients.
Thank you.